So when I started working on this, I was going to do recurrent pregnancy loss. I was going to do IUFT and still a 2-hour talk. So I scaled back and just talk about recurrent pregnancy loss, the known and the unknown. I think I'll start out with talking about a case and the workup, which has been, which is recommended and what should be done. But I think the most fascinating thing has been the unknown causes and idiopathic causes of recurring pregnancy loss. Because as I was telling Dr. Charmila this, I think OBGYN is at a place of such exponential growth in genomics. If you think about how a baby is conceived right up to birth, there are so many genes at play. There are so many pathways at play. One little fault and you have a pregnancy loss. If that little fault in your gene happens again and again, you have recurrent pregnancy losses. So that to me has been, just thinking about the pathway and thinking about what things could go wrong. It's a miracle we have such a big population we have today. So I'll start with recurrent pregnancy loss. There are many causes. I think Dr. Charmila has done a wonderful job explaining that. So the question is what is the probability of finding an etiology of recurrent pregnancy loss without a history of live birth? It's 30% after 2 losses and 33% after 3 losses. So the question has been, do you evaluate after 2 losses or do you evaluate after 3 losses? And so I guess there are different things, whether should you do 2 losses, should you do 3 losses? And one of the things which should probably do 2 losses is if there's fetal cardiac activity was identified prior to loss, a woman older than 35 years old if the couple have difficulty conceiving. So we have a 35-year-old here, gravida 2, comes in for an evaluation of 2 consecutive pregnancy losses without live births. She would like to get pregnant again, but is concerned about another pregnancy loss. Family history significant for husband, sister having recurrent pregnancy losses ×4. No genetic testing was performed in products of conception. And now she comes in, do I need a genetic workup or not? So here's the thing, after 2, there's been a lot of studies done. And what they found was with the 2 big things which the ACOG recommends is karyotyping and thrombophilia workup. And with karyotyping, they found there was no difference. And when I say karyotyping, I'm talking about the parental karyotyping. There's no difference in 2 versus 3 pregnancy losses in parental karyotype. So whether you do it after 2 or you do it after 3, it doesn't matter. So maybe we start after 2. And similarly with thrombophilia, there was no difference in 2 or 3 pregnancy losses in inherited thrombophilia workup. And the thrombophilia workup is basically, and I'll touch upon this a little bit later, but it basically includes factor V Leiden, prothrombin gene, protein S, protein C, factor 13, etc. So workup is initiated. There are known factors of recurrent pregnancy loss, and you can see on the right side, oh, I'm sorry, I went ahead. And you can see on the right side, there's parental chromosome abnormalities, infections, anatomical defects. And again, Dr. Charmila touched upon a lot of these. What about the unknown causes? It's very limited, not much is known, but there have been, and this is where there's so many studies out there which have found these associations between disease. And I'm going to take you through some of these. What are some of the unknown causes to see if, it's worth looking at these a little bit closer if the known etiology has been looked at and is negative. So chromosomes, 2 to 8% chromosomal abnormalities have been seen in recurrent pregnancy loss. Numerical and structural abnormalities seem to be the most common. What are numerical and structural abnormalities? So you have basically, when parents come in, they sometimes have a translocation. What is a translocation? It's basically one arm of the chromosome is translocated to another arm of the chromosome. Usually parents are fine because there's no genetic material which is lost or gained. You have mosaicism sometimes. Again, parents come in with mosaicism. That means they have a chromosome abnormality, but that's seen in only a certain percentage of cells. You may see it in only 4% of cells, but you may not see it in all 100%. Hence, they don't show any features of the condition, or they show very few features of the condition. Robertsonian translocation is basically a translocation, again, which is one chromosome on top of another. But there are very specific chromosomes in Robertsonians. That's why it's considered specific, because those are the most common translocations you do find, which is chromosome. These are the 13, 14, 21, 22 are the ones which you do see. So the question, so those are some of the known causes. Again, Dr. Charmila touched upon the infectious and a lot of the others. I talked a little bit about the chromosomes and the thrombophilia. And again, I will talk about it a little bit more later as far as workup, and try to bring in a little bit more on the chromosomes and thrombophilia later. But I right now want to talk a little bit of the unknown. You know, what else can we do? And before we talk about what else, I think we need to know what else is out there to do. So why does it happen? And as I said, when you look at when a baby is conceived to when the baby is in the placenta and the baby needs a blood flow from the mom, and to when the baby is delivered, there are different things that can go wrong. And I'll give you a couple of examples here. One is something called this SYCP3 gene, which basically cause defects of this gene basically cause problems with the chromosomes forming, and can cause defects in the baby. Though the parental karyotype is normal, but there may be a defect in the baby because of the defect in this gene. What this gene does, as I said, it basically gets the chromosomes aligned together, makes it formed in the baby. If it's not working, this gene, you're not going to have the chromosomes line up as they should be. Telomere length, what is that? That is basically is how long a chromosome is. If a chromosome is fragmented or defective in a certain way, or not being formed a certain way, these chromosomes are super short. And when that happens, it's obviously not functioning well. And when it doesn't function well, you have defects in the baby and in the fetus. And the last thing is defects in certain genes, which can cause problems with embryo implantation and placentation. So there is a male factor, which can cause problems with recurrent pregnancy loss. One is DNA fragmentation. So basically when there's DNA fragmentation in the sperm, you can have problems with embryogenesis and problems with pregnancy maintenance. When the sperm chromosomes are defective, what that means is there's they have a different, I guess for lack of a better word, changes in the size of the chromosomes of the male. That can cause problems in the fetus, and that can cause problems with pregnancy loss. So a sperm work, looking semen analysis is important. Of course, there's micro deletions which cause problems with or in the genes for the azoospermia region, which is so basically what happens is when there's a small deletion in any of these genes, especially this gene, AZFC gene, when a little bit of material is missing, the baby is formed, but the baby can't be maintained. And then you have a recurrent pregnancy loss. So when they did a little bit of research on 2,000 plus spontaneous products, what they found was the parental karyotype was fine, but they found abnormalities in chromosome number in about 60% of the cases, which is huge. And on the basis, they said maybe pre-implantation genetic screening may significantly reduce the miscarriage rate. So, IVF and pre-implantation genetic screening will be important to reduce the miscarriage rate to just 7%. So this is what I was talking about. This is the network, if you see, of all the genes which are super important in maintenance of embryogenesis and maintenance of the pregnancy. There's something called hub proteins, which are basically bottleneck proteins, or they're critical proteins which are important in maintaining the pregnancy. And these are some of the ones listed here. So what are some of these proteins? And I'll give you a couple of examples. There are proteins that help increase the blood flow to the mom, and to the placenta, to the fetus. And so these are the epidermal growth factor proteins, which are important in getting the blood flow glowing. If there's a defect in these proteins, you're not going to have enough blood flow to the placenta, hence the pregnancy loss. This gene called the ENOS gene, which is basically a nitric oxide synthetase gene, because it helps in, again, implantation, and it helps in the perfusion of the placenta. This gene is defective, there's going to be a pregnancy loss. MMP2 and 9 basically prepares the endometrium to receive the baby and the placenta and the pregnancy. And again, there's a defect, you're not going to, there's going to be an issue. The PGR gene, which is a progesterone receptor gene, is helpful for the implantation and maintenance of the placenta. So here we have the genetic variants. We already know of the factor 5 and the factor 2. There are genes which can cause a defects, and they are recommended by ACOG as far as the workup goes. There are other genes which are definitely part of it. One is the protein C activator gene, and they all act on the coagulation cascade. The thrombomodulin gene, the factor 513 gene, and they basically cause issues with the which help with the blood flow, and it helps with enough blood flow. If there's a defect in any of these genes, there's going to be clotting, and there's going to be decreased blood flow. You also have genes that can, and I'm sorry, there's a typo here, I just saw that. But there are other genes which can cause, which are anticoagulant, can cause too much blood flow and hemorrhage, which are your fibrinolysis gene. Again, defects of these genes can cause problems maintaining a pregnancy. So we then have other things which can be an issue, and that's been looked at a little bit more closely now. So we know that females have 2 X chromosomes and males have 1 X, 1 Y chromosome. If both our X's were working all the time, we would be super women, which we are with all the work that we do. But usually 1 X is inactivated, and which X is, and this is in every single cell of our body. Which cell is inactivated, which X is inactivated in each cell is very random. And so that's a normal process, and sometimes 1 X from the mother is inactivated, sometimes the 1 X from the father is inactivated. What happens if most of the cells have X's only from the mother or the father inactivated? That's called skewed X inactivation. That is seen in about 3.3 to 4% of the normal population. So one of the things which was done, which was, I think, groundbreaking, was when about 75 to 80% of the cells are inactivated as far as skewed X inactivation. That's just skewed, but when 90 to 95% of the cells are of the same X, which is, say, inherited from mom or is inherited from dad, is inactivated, it's called extreme skewed X-linked inactivation. And what they found is there's an association between this extreme skewed X inactivation and idiopathic recurrent pregnancy loss with women with 3 or more pregnancies. Not so much with 2, but they definitely found a correlation with 3. Some of the causes which can cause this was if there are defects in the X chromosome gene, diseases such as premature ovarian failure and cancer. And if there are other defects such as on the X gene, which causes oocyte atresia or causes the restriction of the oocyte precursor pool. And when there's a restriction, as we know, this can cause issues with chromosomal number and chromosomal structural defects and numerical defects, causing a chromosomal imbalance. The other thing, what they found was something called methylation, which basically means it's silencing the genes which work. So if there's a gene which is doing its job and it's silent and it goes silent, it's not going to do its job. So if there's a defect in this, you're going to have a problem. So there can be defects in in issues with immune signaling pathways, in different genes associated with lipid metabolism, and all these, for some reason are connected with pregnancy and maintenance of pregnancy. And diabetes also causes this issue, which is silencing of this gene, which causes a recurrent pregnancy loss. So because diabetes causes increased stress to the body and things like that. So what an eye-opener here, how a lot of these diseases such as cancer and diabetes can cause issues with the genes, which causes pregnancy loss. Immunologic causes. So again, immune causes can cause issues with stress and inflammation in the body, and that can basically cause issues with trophoblastic implantation. And so some of the examples are interleukins and tumor necrosis factor. And these changes are thought to be mediated by estrogen and progesterone. Estrogen is pro-inflammatory, progesterone is immunosuppressive, and usually there's a balance. So if these genes are causing a defect, there's not going to be a balance, and there's an issue with maintenance of pregnancy. This is a new topic. Basically, we've touched on genes, we've touched on chromosomes, we've touched on thrombophilia a little bit. This is something called microRNA. It's very, very new. It's something which has been looked at in all aspects of cancer, different chronic diseases, and now it's being looked at in pregnancy. And what these are basically is non-coding genetic information. So they don't code for any gene specifically, but it still has an important role in the function of the gene. So when there's a defect in these microRNAs, the genes are not going to function well, and that's going to cause issues with idiopathic recurrent pregnancy loss. So specifically, they found this MIR16 has been found in villi and decidua of patients. And this causes issues with placentation and angiogenesis. So, I kind of wanted to talk about these causes a little bit and touch upon them to see, where we are and where we are going as far as a workup with, these pregnancy loss, because patients will have questions and, we need to give them answers. And so the American Society for Reproductive Medicine basically looked, and the way they did it was looked at 1938 cases, and they found the complete evaluation as far as, which is thrombophilia and chromosomes. They found it in normal and abnormal. Abnormal workup they found in 42.9% of pregnancies, where they found problems with the parental karyotype. They found problems with uterine anatomy, endocrine, and antiphospholipid antibodies. The normal is, if you see, is still 57%. So how much of this is because of the unknown causes? These are the European guidelines, which are there. And I don't know if you can see the recommendation, which is in blue. You can see the ones which are in yellow, which are tests that can be considered. And you can see the genetic tests here. The genetic tests include the chromosomes, the thrombophilia workup, right here, and then sperm DNA fragmentation tests. And then the non-recommended tests are what we touched upon, which is, let me go back, which include cytokine testing, interleukin testing. They are not recommended as of yet because although they found some associations, it does need to be looked at much larger populations to see if it's worth testing for it, and secondly, the cost of it. So what they did look at was the different recommendations from Royal College in 2011, the American Society of 2012, EHSRE guidelines, and then the EHSRE proposed guidelines. What they are proposing is not do parental karyotype unless we do a chromosome microarray on a fetus. So they are saying is if there have been 2 or more recommended pregnancy losses, let's start with a microarray. Only if they have found an unbalanced translocation where they found chromosomes which are with genetic information lost or increased, should we do a parental karyotype for further genetic counseling and maintenance of pregnancy. Uh, the products of conception cytogenetic analysis, they do recommend chromosome microarray, not cytogenetics. And for the problems, again, Dr. Charmila mentioned, there's an issue with chorion-Willis sampling, the transportation, the material gets degraded, and there are a lot of false negatives. So chromosome microarray, probably because you're extracting DNA out, you will probably get a better bang for your buck. Or I know it's expensive, but you're probably going to get a quicker answer with that than if you did with just chromosomes. So there has been a new algorithm which has been recommended, is that which we talked about, and what they found is with at least the known causes, if you do the thrombophilia workup and a microarray without doing the parental karyotype, you will come close to 91.8% at least of the known pregnancy, the known recurrent pregnancy losses, and a possible explanation. So what, after the second pregnancy loss, again, Dr. Charmila touched upon this a little bit. I'm going to go straight to the white, which is products of conception, which is if you look at the products of conception for the microarray, if it's normal, then you want to look for the other causes. And then if it's abnormal, and if it's abnormal, if it's an unbalanced translocation or it's an inversion or something that says we need, parental karyotype, or there's a report that says parental karyotype, genetic counseling is needed to, to see if it's inherited from which parent, then we do a parental karyotype. If the product of conception is not normal, but it's not because of a chromosome abnormality in the parent, but it's a chromosome abnormality because of, the issues we've discussed before, whether it's a genetic defect, it's a gene defect, or it's a fact of sperm DNA fragmentation, etc. Really no further testing is needed, and we go on to expectant management, such as maybe we consider pre-implantation genetic screening with IVF, etc. The unexplained cases, if the chromosomes, you're not showing anything, consider the hereditary thrombophilia workup. If there is a strong family history of bleeding disorders, or if there's a strong family history of, or a personal history of a person not being able to, of having an emboli or having multiple thrombus, etc., then we go ahead with the thrombophilia workup. Consider sperm DNA fragmentation testing, and then go on further after that. After the third miscarriage, if no testing has been done, then you, I guess, investigate and manage according to the above algorithm. And if the above algorithm has been followed in the previous miscarriage, repeat POC testing with every recurrent pregnancy loss, and complete the workup if it's not, full workup if it's not possible done. And if all possible known etiologies have been addressed, and product of conception abnormalities has been repetitive. What I mean by that, you are always seeing a chromosome abnormality in the product of conception. You would consider IVF and pre-implantation genetic screening to lower that as much as we can. This is a very personal loss for every patient, and we try to provide answers. What I try to do is basically give a glimpse into what we do today and what we are going towards in the future. In 5 years, whatever I have touched upon right now is probably going to be part of a panel, which you would do with patients with 2 or more recurrent pregnancy losses, and say, let's do your full workup. Let's get to see where the bottom line is, and then proceed from there. This is not only about about managing future pregnancies, but it's also helping a mother and a father grieve for a loss of their child and providing answers for them as to why this has happened. Thank you.